biopsy. They're looking for those little ganglion fibers. Surgery in 2 stages. There's a temporary ostomy. Second stage is pull-through procedure. Vomiting. Therapeutic management directed at treatment of cause with fluids administered the same as for diarrhea and use of antiemetic drugs such as Zofran and Reglan. Nursing considerations are to determine the cause of the vomiting, use proper feeding methods, position on side to prevent aspiration. GER, gastroesophageal reflux. Definition as transfer of gastric contents into the esophagus. Occurs in everyone. Frequent and persistency may make it abnormal. May occur without GERD. GERD may occur with regurgitation. What's GERD? What's the difference between GER and GERD? Upper diagnostic is a GI series. Therapeutic management, thickened feedings. Avoid citrus, tomatoes, peppermint, spicy and fried foods, and caffeine. Nursing considerations, identifying children with symptoms, educating parents on care, and feeding and med administration. Functional abdominal pain disorders. Etiology higher in the winter suggests school stress and daylight hours, and persons who share 1/2 your genes, first-degree relatives. That's a first-degree relative shares half your genes. Thought to be presence of altered brain-gut interaction. Diagnostic evaluation is a CBC and ESR. What is an ESR? Liver transminases, celiac antibodies, and stool for blood, ova, and parasites, and a urinalysis. Acute appendicitis. Etiology and pathophysiology is the obstruction of the lumen of the appendix by feces or swollen lymph node matter, usually after an infection. Diagnostic evaluation: fever, vomiting, abdominal pain, increased WBCs, McBurney point midway between the umbilicus and iliac crest, and a CT scan. Therapeutic management is usually antibiotics and surgical removal before it perforates. Acute appendicitis. The prognosis is good with early intervention. Nursing care management is to assess the amount of pain, observe behavior. Do not give enemas or laxatives as stimulus could perforate. So anytime you suspect appendicitis, no stimulus, no laxatives, and no enemas. Meckel diverticulum. It is the most common congenital malformation of the GI tract. Occurs in 1 to 3% of the population. Pathophysiology is bleeding. Intersusception. What's intersusception? Intestinal obstruction, diverticulitis, and perforation. Diagnostic evaluation is a H&P, radiographic study, painless rectal bleeding, signs of intestinal obstruction. Therapeutic management is surgical removal of the diverticulum, and prognosis is good when treated. Nursing considerations, as with any surgery, and support to parents. Vital signs: bed rest, record the amount of blood lost in the stools, and IV, NG tube to decompress. Inflammatory bowel disease includes ulcerative colitis and Crohn's disease. Etiology and pathophysiology not completely understood. Diagnostic evaluation: you want to take an H&P, a CBC, an ESR, stool for blood and infectious, and a GI series. Therapeutic management is to control the inflammation. Medical management, treatment, remission long-term, promote normal growth and development. Beyond hospitalization, as to diet management, avoid stress and emotional lability. Adjusting to your disease with remissions and exacerbations, and preparing for possible bowel surgery. Peptic ulcer disease. Etiology and physiology unknown, although infections, genetics, and environmental factors are important. Diagnostic evaluation is based on symptoms, physical examination, diagnostic tests, upper GI series, diet history, use of alcohol, tobacco, and NSAIDs. Therapeutic management. Medical use of antacids, histamine, PPIs inhibit hydrogen pump, mucosal protection agents, and bismuth agents. Surgical vagotomy and pyloroplasty. Nursing considerations promote healing of the ulcer with meds, Tylenol but not NSAIDs, for pain, critically ill infants and children, and decrease stress. We used to have babies in the NICU that would get stress ulcers. So that constant lights on, constant hearing those noise, being overstimulated all the time, that'll cause an ulcer real easily. Acute hepatitis causes a virus, chemical reaction, drug reaction, or other disease processes. Hepatitis A is the most common through stool. Remember that. Hepatitis B via parent. It's low in the United States, high in Asia and Africa. Hepatitis C from mothers, blood transfusion. Hepatitis D, acute liver failure, hemophiliac, and IV drug users. Hepatitis E, externally through fecal oral route. Hepatitis G comes from organ transplantation. Acute hepatitis, the causes. Yes, we did that before. Non-A, non-B hepatitis. Therapeutic management goals: early detection, recognize chronic, and prevent spreading. The prognosis depends on type of the virus. Nursing considerations depend on severity. Educate parents in type, cause of administration of meds, sleep and rest, transmission. Infection control: prevent spread of disease by good hand washing and vaccines. Biliary atresia. It's known as extrahepatic biliary atresia. Etiology and pathology: exact cause is unknown. Diagnostic evaluation key is to have surgery. If no surgery, you get cirrhosis. Therapeutic management: a segment of intestine is anastomosed to resect portal to drain bile, mostly supportive care. Prognosis: if surgery is done before hepatic ducts are destroyed, will drain bile. Nursing considerations: support the family before, during, and after surgery, post-op care, same as abdominal surgery, and give all support while waiting for transport. Cleft lip, cleft palate. Facial malformations that occur during embryonic development may appear separately or together. Etiology and pathophysiology and diagnostic evaluation. Got some good pictures here of these different cleft lip, cleft palate. There's the lip, and that's what the palate looks like. Surgical correction of cleft lip. Closure of lip, defect precedes correction of the palate. The palate takes a long time. Z-plasty to minimize retraction of scar. Protect suture line with Logan bow or other methods. Logan bow. Surgical correction of the cleft palate. Typically 12 to 18 months of age. Effects on speech development, must have some degree of speech impairment. Teeth are misaligned, some hearing loss from otitis media, scarring of the tympan membrane, threats to self-image, and social and emotional adjustments. Prognosis is that of above. Nursing considerations support parents while feeding and caring for infant to wait for surgery. Use of special nipples like a lamb's nipple we used to use in the NICU or others. What do you think their biggest problem is? A child with a cleft palate. When you see that palate split like that, what do you think that their biggest problem is? Special feeding equipment. Breastfeeding issues place nipple back in oral cavity to allow tongue to assist with milk. Expression of breast milk can be pumped. Have mother feed ASAP so that an acceptable method can be determined prior to discharge. You want her to be able to feed this child without choking, aspirating, or coughing all the time. And you want her to get comfortable with feeding this child so she could take the child home and have it thrive so that 18 months, 12 to 18 months, they can come back and get that palate fixed. Esophageal atresia and tracheoesophageal fistula. Failure of the esophagus to develop as continuous passage. May occur separately or in combination. The etiology and pathophysiology equal in male and female. Low birth weight, premature with polyhydramnios. EA and TEF, most common. Diagnostic evaluation, polyhydramnios. And what is polyhydramnios? Clinical manifestation, surgical emergency. It is a surgical emergency. There. Your esophageal atresia. It's not complete. There's nothing complete there. It's a blind pouch. This one doesn't even connected. This one went through and doesn't connect. And this one's going nowhere also. 5 most common types of esophageal atresia and tracheoesophageal fistula. Management. Surgical intervention emergency. Prognosis related to birth weight and anomalies. Associated tracheomalacia. Nursing consideration. Diagnose before and initial feeding. Aspiration. Unexplained episodes of cyanosis should be suspect. Post-op. Same care as high-risk newborn. Gastrostomy. Tube is connected to gravity drainage. Above stomach level, trach is suctioned with a pre-measured catheter to avoid a suture line. Before oral feeding, the chest tube is removed. Accessibility of the infant to feed, swallow without choking. Teach parents to care for the child with anomalies and post-op care, which is appropriate to the situation. And you'll find all this information on page 849. Hernias. Definition is a protrusion of a portion of an organ through an abdominal opening. Danger of incarceration or strangulation. That's the big problem. And we do what's called a reduction. If you can push it back in where it came out of, nice and easy, that's fine. Pediatric hernias, they're diaphragmatic, hiatal, or umbilical or abdominal wall defects. Omphaseal and gastroschisis. What's gastroschisis? Omphalocele. Hypertrophic pyloric stenosis. Constriction of the pyloric sphincter with obstruction of gastric outlet. There you can see And the stricture.